Okay, welcome back, everyone. Our next speaker is our very own uh, Alisa Villa, our PharmD critical care pharmacy resident, and she's talking. She's going to give us a talk on blood pressure management in stroke. Thank you,
Okay,
Alisa. Take it
thank
away.
you, Karen. Good morning, everyone. As previously mentioned, my name is Alyssa Avila, and I'm currently the PGY2 pharmacy resident in critical care. And today I'll be doing an overview on the blood pressure management in our stroke patients. For the objectives of my presentation today, first we're going to review blood pressure management in stroke patients. Then we'll evaluate the guidelines and evidence supporting blood pressure goals in stroke. And then we'll discuss some common antihypertensives and vasopressors in our stroke management. Here's some abbreviations that I will be referencing throughout my presentation today. Just as an introduction, in 2021, 1 in 6 deaths from cardiovascular disease was due to a stroke. And every 40 seconds, someone in the United States has a stroke. And every 3 minutes and about 14 seconds, someone will die of a stroke. Stroke is the leading cause of serious long-term disability and can reduce mobility in more than half of stroke survivors age 65 and older. Stroke is subdivided into two distinct categories, our ischemic stroke and hemorrhagic stroke.
Miss Alisa?
Yes.
Your slide's not in slide mode and not advancing.
Oh, do you see the first?
We do.
Yes. It's not in presentation mode though.
Slideshow.
When I go like this, it's not going.
Go to slideshow. It's still on. It's not in slideshow mode.
Oh,
There you are. There's your objectives.
let me try that again.
Try to advance now.
Okay, how is this?
Yeah, there you go.
Yes. Great. Perfect.
Okay, my apologies. So from here, I'm going to now talk about stroke between our ischemic stroke and our hemorrhagic stroke. I'll go through each of them one by one. Here we have acute ischemic stroke, and I'll first talk about our pathophysiology, and then I'll talk about the clinical practice guidelines. As for the pathophysiology on ischemic stroke, this is a manifestation of neurological deficit due to an occlusion of a cerebral artery, causing a reduction in cerebral blood flow. The major mechanisms underlying an ischemic stroke are due to an occlusion of an intracranial vessel by a distant traveling embolus, an in situ thrombus of an intracranial vessel, and stenosis of a major extracranial artery. Ischemic stroke does account for about 87% of all strokes. However, advancements and improved care has led to an increase in survival. Now talking about the recommendations, this is directly from the 2019 updated AHA-ASA guidelines for the early management of acute ischemic stroke. And it's broken down between our emergency treatment for blood pressure and also just our general in-hospital management for blood pressure. In terms of emergency treatment, patients with an elevated blood pressure that are eligible for IV alteplase should have their blood pressure carefully lowered to a blood pressure less than 185 over 110 millimeters mercury before an IV thrombolytic is initiated. Patients that are planned to have a mechanical thrombectomy and are not getting IV alteplase or a fibrinolytic, it is also reasonable to maintain a blood pressure that is less than or equal to 185 over 110 millimeters of mercury prior to the procedure. In patients for just our general hospital that are not going to get an IV thrombolytic or an anticipated mechanical thrombectomy, and their blood pressure is greater than 220 over 120, and they have no other conditions to urgently drop it, it may be beneficial to reinitiate an anti-hypertensive 48 hours to 72 hours is really uncertain, but lowering that blood pressure by 15% in the first 24 hours. And this is really for our permissive hypertension to allow that perfusion to the brain. So just as an overview, this is a schematic that I put together. We have our ischemic stroke, and it's broken down between our patients that will get a thrombolytic or mechanical thrombectomy and those that will not. When we look at the top, we have our thrombolytic and our mechanical thrombectomy, and we want to lower that blood pressure to less than or equal to 185/110. And once the patient receives their thrombolytic, to go ahead and lower that blood pressure to less than or equal to 180/105. In our patients that are not getting a thrombolytic or a mechanical thrombectomy, it's then categorized between patients that have a blood pressure that is less than or equal to 220/120 and those that are greater than that. For patients that are less than or equal to 220/120, treatment's actually not recommended here for that permissive hypertension. And then patients that have been elevated beyond the 220, the recommendation is to potentially lower the blood pressure by 15% during the first 24 hours. And beyond that, it's really uncertain on how they want to manage the blood pressure. And the 2019 guidelines actually give some recommendations on specific antihypertensive agents. They break it down between our continuous infusion and intermediate IV pushes. For continuous infusion, we have our labetalol, nicardipine, clofidipine, and sodium nitroprusside. For our intermediate IV pushes, they recommend labetalol, hydralazine, and enalapril. Later on in this presentation, I'll actually dive into all of these categories of medications and talk about the different agents and how we'll use them. Next, we're going to talk about hemorrhagic stroke, the pathophysiology, and the clinical practice guidelines here. As for some pathophysiology, we have our intercerebral hemorrhage, RCH, is defined by brain injury attributable to acute blood extravasation into the brain parenchyma from a ruptured cerebral blood vessel. Some common causes of our ICH include uncontrolled hypertension, which is our most common, antithrombotic or anticoagulant therapy, cerebral amyloid angiopathy, and drugs of abuse. Though it is less frequent than our ischemic stroke, it does have a significantly higher mortality rate of nearly 50% versus 25% for our ischemic stroke. Now talking about the guidelines, here are some recommendations on the blood pressure management pulled from the 2022 AHA-ASA guidelines on the management of spontaneous intercerebral hemorrhage. And those recommendations are actually broken down between the severity of the hemorrhage. So in patients with spontaneous ICH of mild to moderate severity with a systolic blood pressure between 150 and 220, the acute lowering of a systolic target to 140 with the goal of maintaining a range of 130 to 150 is safe and reasonable. Additionally, in patients with spontaneous ICH presenting with a large, going back, so we have the recommendations I had left off after the mild to moderate. As for our patients that are presenting with a severe intracranial hemorrhage, and they may potentially be requiring a surgical decompression, the safety and efficacy of intensive blood pressure monitoring are not well established at this time. And then this is just the schematic that I put together as an overview between the type of hemorrhagic stroke, depending on the severity. It's our mild to moderate versus severe. And our patients with our mild to moderate and are presenting with a blood pressure between 150 to 220, the guidelines do recommend that target blood pressure goal of 140 millimeters of mercury with that range between 130 to 150. In our patients that have the mild to moderate with a systolic blood pressure greater than 220, there's actually a knowledge gap in this area, and they don't define recommendations on what the target should be for that blood pressure. And again, for those patients that are presenting with a severe hemorrhagic stroke, there is currently a knowledge gap due to that insufficient data. Therefore, there aren't actual parameters listed in the guidelines at this time. Okay, now talking about the different pharmacotherapy options for antihypertensives that are listed in the guidelines. I'm going to do an overview on the different classes of medications that are listed. We have our ACE inhibitors, beta blockers, calcium channel blockers, and our vasodilators. So first, talking about our ACE inhibitors. Here I have listed just the overall normal pathophysiology of the ACE, which is our angiotensinogen converting enzyme. And then I'll talk about once we give an ACE inhibitor, what this does. So as we might know, our angiotensinogen converting enzyme ACE is part of the renin-angiotensin-aldosterone system. Our ACE converts angiotensin 1 to angiotensin 2, and this leads to vasoconstriction through multiple mechanisms. And this is done through vasoconstriction, sodium water reabsorption, aldosterone release, and our antidiuretic hormone release. Once we administer a patient with an ACE inhibitor, this will inhibit that angiotensinogen converting enzyme, and therefore will prevent our angiotensin 2 and inhibits the downstream effects of our vasoconstriction. Next, we'll talk about our beta blockers. Here I have the normal pathophysiology for our beta receptors. These are a type of adrenergic receptor, and when stimulated, this will result in a fight or flight response to perfuse our vital organs. This increases chronotropy, increases our stroke volume, our ionotropy, and overall our blood pressure. As for the mechanism of action, when we administer a beta blocker, this will lower our blood pressure by blocking the sympathetic activation of our beta-1 receptors. So we'll see a decrease in our stroke volume, decrease in our cardiac output, and an overall decrease in our blood pressure. Okay, next we'll talk about our calcium channel blockers. The normal pathophysiology, so we have calcium channels that are located on our vasculature, smooth muscle cells, and also our cardiac muscle cells. And this results in vasoconstriction and an increase in our heart rate and contractility. When we administer a calcium channel blocker, this will obviously block the calcium channel and will lead to an overall in vasodilation, can lead to a decrease in heart rate and cardiac contractility. But I also want to mention in terms of patients that are presenting with a stroke, we're actually talking about our dihydropyridine calcium channel blocker class, which is more selective for our vasculature and not as selective for our cardiac muscle cells. And the last class that the guidelines mention are vasodilators. And the one agent in this class is our sodium nitroprusside. And as previously discussed, intracellular calcium is needed for that smooth muscle contraction. So I have a visual here. We have our sodium nitroprusside, which releases nitric oxide, and that then goes into our smooth muscle cell. And we have our soluble guanylyl cyclase to form our cyclic GMP. Our cyclic GMP will inhibit our calcium into the cell and leads to an overall smooth muscle relaxation. Okay, now we're going to talk about going a little further into these agents that were recommended into the guidelines. So first we'll talk about our titratable agents. We have our nicardipine and clobidipine here. Both of these fall into the dihydropyridine calcium channel blocker class. And we have our dosing recommendations, our initial dosing, and our titration parameters. Really comparing these two agents, we have our onset, duration of action, contraindications. The onset for our nicardipine does take approximately 5 to 10 minutes. In comparison to our clobidipine, that onset of action takes somewhere between 2 to 4 minutes. So it is quicker in our clobidipine group. As for the duration, we're looking at our half-life for these agents. The half-life for nicardipine is approximately 4 to 6 hours. In contrast to our clobidipine, this is about 5 to 15 minutes. So you'll notice that our clobidipine does have a quicker on-off effect. As for contraindications, they're both dihydropyridine calcium channel blockers. Therefore, we typically will avoid its use in an aortic stenosis patient. I also want to mention our clobidipine. We also want to avoid in our patients that may have an allergy to soybean, soy products, or defective lipid metabolism, as there are lipids in this medication. Two other agents that were mentioned in the guidelines are our labetalol and our sodium nitroprusside. First, we'll talk about the labetalol. This is a non-selective beta and alpha receptor blocker. I have our dosing and dosing titrations listed here. As for the onset is less than 5 minutes, and that half-life is about 5.5 hours. And we'll typically avoid this agent in our patients that have COPD or severe bradycardia. As for our sodium nitroprusside, this is a vasodilator. I have our dosing administration here, and that onset is also pretty quick, less than 2 minutes, and that half-life is about 2 minutes. And we'll avoid using this medication in our patients with acute heart failure or recent use of a PDE5 inhibitor. Now talking about those intermediate IV pushes listed in the guidelines, we have our enalapril, which is part of our ACE inhibitor. I have the dosing 1.25 to 5 mg every 6 hours. Onset is less than or equal to about 15 minutes, and that half-life can be about 6 hours. Contraindications, we don't want to use this in patients that do have ACE inhibitor-induced angioedema. And there's also a black box warning for using this medication. We don't want to use this in patients in their second and third trimester of pregnancy, as there is that potential to result in fetal injury or death. As for hydralazine, the mechanism of action of this medication is largely unknown, but we put it in our vasodilator class. As for the dosing, ranges from 10 to 20 mg IV push, and we can go ahead and repeat from there. The onset can really vary. This can range between 10 to 80 minutes, depending on the patient, and that half-life is anywhere between 3 to 7 hours. And we typically try to avoid using this in our CAD patients. And then the last one, we have our labetalol, which I just discussed with in the infusion slide. But the dosing here is to use in our patients between 10 to 20 mg, and we can go ahead and repeat this if needed. Okay, now we're just going to talk about some of the existing literature surrounding these different infusions in our stroke patients. The first, what I'm going to talk about, I'm going to go over 5 different slides that are really comparing nicardipine compared to clofidipine. I have the author, population, the intervention that was used, and then all of these articles actually go over the time to our goal blood pressure. And then I have some other notable outcomes from these articles listed at the end. So for our first trial, we have Saldana, published in 2022. This was a retrospective trial looking at patients with hemorrhagic stroke, a total of 89 patients. And in the intervention that was used was our nicardipine starting at 5 mg an hour, and our clofidipine starting at 1 to 2 mg per hour. And in that time to goal blood pressure, you'll see that nicardipine did get there a little sooner at 30 minutes compared to 45 minutes. However, this was not statistically significant. Some other outcomes that were looked at, they found no significant difference in the need for additional anti-hypertensive, and also the percent of time to our goal systolic blood pressure or our hematoma expansion. As for an article from Martini in 2022, this was a retrospective trial looking at patients with acute CVA, a total of 71 patients. And the intervention group was very different here. They compared pharmacy-made nicardipine to a pre-made clofidipine. So this pharmacy-made nicardipine had to come from the pharmacy, which already would put a patient at a delay when they're receiving this medication. And you'll also note that the starting rate was lower in this group as well. They started the nicardipine infusion at 2.5 mg per hour and titrate from there, in comparison to our pre-made clofidipine starting at 1 mg an hour. As for our outcomes, that goal to systolic blood pressure, it was much lower in our clofidipine group at 69 minutes compared to that nicardipine at 151, and this was found to be a statistically significant difference. As for other outcomes that this article looked at, there were no significant differences found in percent of time at goal blood pressure. The third trial, Rosenfeld, in 2018. This was a retrospective trial looking at ischemic and hemorrhagic strokes, and it did have a larger population size, 269. And they compared nicardipine to clofidipine. However, there was no mention of the rate that was used in this group. And what they found was that nicardipine did get to goal blood pressure at 65.5 minutes compared to 65.8 minutes. So pretty comparable. However, this was not a statistically significant. And other outcomes that they looked at, there was no significant difference found in the percent of time at goal blood pressure, composite of readmission, rebleeding, hemorrhagic conversion, or hematoma expansion. The last two articles that I'll talk about comparing our nicardipine to clobidipine is Allison in 2017, retrospective trials, 210 patients, compared our nicardipine to clobidipine, and that time to our goal blood pressure was shorter in our clobidipine group at 50 minutes comparison to nicardipine at 74. And then the last trial, we have Finger in 2017, retrospective, trial size was 57 patients, compared these two medications, but there was no mention on the infusion that was used. And they did find that clobidipine did get to goal blood pressure at 30 minutes in comparison to our nicardipine at 46. However, there was no significant differences found in percent of time at goal blood pressure. Now I have some visuals that I'll just briefly go through. This was compiled together in a systematic review that actually went through all of the 5 trials I just discussed and pulled out different outcomes and compared all of them together. So this first one, this outcome looked at the total volume of infusion, comparing clobidipine to nicardipine. You'll see for the clobidipine group, it actually ranges from 236 ml up to 530 ml for the total volume infused, in comparison to our nicardipine group, which range from 500 ml up to 3 liters. So you'll see the standardized mean difference at minus 0.52. So it was overall lower for the total volume that was infused in our clobidipine group compared to our nicardipine group. Next outcome was the need for other antihypertensive agents. You'll see here we have the clobidipine and nicardipine, and here we have an odds ratio of 1.15. So you'll see that typically there was a little bit more need for antihypertensive drugs in that nicardipine group in comparison to the clobidipine. Next, we have looking at some safety parameters. This was systolic blood pressure less than 120. That was reported in our clobidipine and nicardipine. And you'll see that odds ratio of 1.57 the reading of a systolic blood pressure less than 120 did happen more frequently in our nicardipine group. And here I have some outcomes, hospital length of stay. You'll see for clobidipine, it does range from a hospital length of stay of about 9 days up to 12, and our nicardipine group does range from about 7 days up to about 10, almost 11 days, and a standardized mean difference of 0.15. So really, they didn't find much of a difference between these two groups. And here we have ICU length of stay comparing the two, clobidipine and nicardipine. Clobidipine ranging between 5 to 10 days, and our nicardipine group ranging between 5 to 9 days as well. And we have a standardized mean difference of 0.19. So really, overall, not a big difference between these two groups as well. Now, the guidelines also mention the use of labetalol. And so I looked at some of the trials that exist using labetalol in our patients with stroke. And there was an article by El Ghouri in 2021, retrospective trial, about 3,000 patients, comparing nicardipine to labetalol. And what they found was that time to goal blood pressure in labetalol was about 24 minutes in comparison to nicardipine at 40. And then the last trial looking at labetalol in our stroke patients was Hetch in 2018, retrospective trial, about 99 patients. And they stated an average infusion of our nicardipine and labetalol. And they actually reported their outcomes in terms of percentages for time to goal blood pressure. And it was a little bit lower, 67% compared to our labetalol at 68%, though this was not statistically significant. Okay, so some key takeaways overall for our antihypertensives. Overall, there is evidence to support the use of clobidipine, nicardipine, and labetalol for our stroke patients. And clobidipine may achieve time to blood pressure goal quicker than nicardipine. However, the data does not suggest that this significantly improves patient outcomes. Okay, now we'll go ahead and talk about the pharmacotherapy with our vasopressors. So looking at our guidelines, both the 2019 and 2022 guidelines for our ischemic and hemorrhagic stroke both state to maintain adequate perfusion. So as we may need our antihypertensives, we also could potentially use some vasopressors to maintain adequate perfusion for our patients. So our vasopressors in our stroke patients, vasopressors create constriction and increase cardiac contractility. During a stroke, the cerebral perfusion pressure decreases, and there is a risk for inadequate blood flow to the brain. And as you may recall, there's an equation. We have our cerebral perfusion pressure is equal to our MAP minus our ICP. As for the general pathophysiology, for our vasopressors, we have our catecholamines or sympathomimetics that mediate this cardiovascular action predominantly through stimulation of our alpha-1, beta-1, beta-2, and dopaminergic receptors. As for our beta-1 stimulation, this results in our myocardial contractility, and our alpha-1 stimulation results in our vascular contraction and an overall increase in SVR. And here I just have a general overview of how this happens. Here we have our alpha agonists, which will then go and act on our alpha-1 receptor, and we have a downstream effect of essentially vasoconstriction. And then we have our beta agonist, which will go ahead and work on our beta receptors, and this can go ahead and downstream lead to a positive chronotropy and positive ionotropy. And here I put together a chart of our most common vasopressors that we see. We have our dopamine, dobutamine, norepinephrine, epinephrine, and phenylephrine. I have the dose ranges listed that we'll use. And what I really want to point out is the different parameters that these medications work on, and also the different receptors that they work on as well. For example, we have our dopamine, and this will primarily work on increasing our systolic blood pressure and our MAP. And as you can see, it's more selective to our dopamine receptors. As for our dobutamine, this will go ahead and increase our systolic blood pressure, and it's primarily selective to our beta-1 receptor. As for our norepinephrine, this will increase both our systolic blood pressure and our MAP, and you'll see that the selectivity is more selective towards our alpha-1, though we do see action on our beta-1 and beta-2 as well. And then we have our epinephrine, which will primarily increase our systolic blood pressure and our MAP, and this works. You'll see more selectivity in comparison to our levofed for that beta-1 receptor, though it does work on our alpha-1 as well. And then last, we have our phenylephrine. This one really only increases our systolic blood pressure and works primarily on our alpha-1 receptor. Okay, now looking at some of the existing literature for vasopressors and in our stroke patients. This was one article that I pulled, Vasopressor Therapy in Acute Ischemic Stroke. This is an updated systematic review just published in 2023. So this was to give just an overview of the existing literature that's out there for our stroke patients. Overall, there's 27 studies currently assessing pressor therapy in acute ischemic stroke. Out of those 27 studies, phenylephrine was the most commonly used agent to increase blood pressure. A total of 16 studies assessed this. For norepinephrine, there were 6 studies, epinephrine, 3 studies, and dopamine, only 2 studies. Though there is theoretical argument for preferred vasopressor choice in stroke patients, unfortunately, there is limited data to suggest superiority of a particular agent at this time. So some key takeaways for our vasopressor therapy. The goal for vasopressors is to increase our ICP. Theoretically, an agent that would increase our MAP would also increase our ICP. However, at this time, there are no head-to-head trials that investigate preferred vasopressor therapy in stroke patients. And at this time, phenylephrine appears to be the most studied drug. However, phenylephrine does not have an impact on our MAP. It only works on increasing our systolic blood pressure. So overall conclusions from this presentation, the overall goal in stroke is to really maintain adequate cerebral blood flow. And this is maintained through a combination of our antihypertensives or our vasopressor therapy. And guidelines recommend multiple agents for antihypertensives, with existing literature not showing strong evidence favoring one agent over the other at this time. And there is a lack of data available on the preferred vasopressor for stroke, but phenylephrine appears to be the most studied right now. And then these are my references. And with that, that concludes my presentation.
Thank you, Alisa. It's great.
Thank you.
If you have any questions for Alisa, put in the chat, please. So I know we asked Elisa to present blood pressure management, and actually we wanted, she did talk about nicardipine versus clavaprax, because I always say we're spoiled here, and we use clavaprax since the beginning of stroke program, and then because like the research shown that it does reach goal faster in some of the studies. And then we are trying to conduct our own study with our own data to look at the efficacy, how fast we can get to goal. And we haven't used Cardine, as our first choice in Pomona, so we're partnering with St. Jude because they use primarily Cardine. So we're comparing data, and hopefully we have an IRB study together with our data combined. So that's what we're trying. Yeah, so we'll keep you posted. Maybe we'll share what we have next year symposium. All right. Any question for Elisa? I don't see. All right. Thank you so much, Elisa.
Thank you, guys.